Welcome, everyone. Thank you for joining us. Today, you are here to learn all about medications, and we're going to talk about medications and COPD. So we call it Medications and You. Myself, Alexa McMillan, one of the co-hosts for this series, and Lindsay Wetterstrand. You know us well. We've been giving you guys some education since the beginning of this year. We're here to talk a little bit about a topic that we're very passionate about. And yeah, Lindsay, anything you want to say?
No, like Alexa said, this topic is extremely important, as we're going to highlight throughout the presentation, because everybody's on different medications and different medications work differently for all of us. So hopefully we'll clear up some of your questions today. We'll take them at the end, so throw them in the chat box, which will be great. If you need one of your devices demonstrated, I think we have a few demos we can actually demonstrate for you. But other than that, because of me and we're late, I apologize. We're just going to jump right into it, okay? You want to click the next slide?
Gotcha.
Thank you. So the topics, like we said, we'll be talking about the different medications that are available. We will not be going into very specifics, more kind of broad categories. We'll address why are there so many devices. We'll address common misconceptions and errors, and then we'll talk about some new medications that some of you may have heard of or be on, and then we'll tackle our questions and answers.
Yeah, and there'll be lots of time for question and answers at the end.
We'll make sure we commit enough. So just a quick disclaimer. Yeah, we can go to the next slide. Like I said, each patient is different. That's what makes us all so glorious and special. Okay, we all know this. Mommies and daddies told us that we were so special when we were kids. So that means each medication is going to affect everybody differently. What may work for me won't work for Alexa, okay, or vice versa. Just because she had great results doesn't mean it's going to work for me. It also takes your healthcare provider time to find the right combination of medications that will work specifically for you. I know it's frustrating. You want to just get one medication and get going, but it does take time, okay? And just one minute done. And we'll talk about technique and adherence to how it's prescribed, because that's key for making the medication actually work properly for you. Okay.
All right, so let's dive in a bit into this. When we think of respiratory medications, there is a lot of questions that can come up. What are they? What type of medications they are? How many there are? Why are there so many? What is the difference between a bronchodilator and an inhaled corticosteroid? The difference in the types of devices that they come in. Why are there so many different ones out there? And how to figure out which one is right for you. So we're going to try and help answer some of these questions. So when you look at this page, this is just a glance at some of the puffers that are out there on the market. And every year it seems to be that there's more and more that are added to this list. So you might see some of the ones that you're on or you've previously been on. This is just to give you a little glimpse that, you know, there are some to choose from. So types of medications that are out there, we have bronchodilators. So you may hear this term. You know, I take a bronchodilator. A bronchodilator is something that helps open up those airways. I like to think about it as it's a muscle relaxant for the airways. Our airways have these muscles that go around them. And when we feel short of breath, those muscles can be tightened. And what this medication does is tell those muscles to relax, to help open up our airways so that we can get that airflow in and out. Then we have inhaled corticosteroids. So these are also known as anti-inflammatory. So they help reduce the inflammation inside of the lung. These types of medications, the medication in these devices, you might not feel it right away, but what they're going to help do is reduce that inflammation that causes a lot of these symptoms that we feel: shortness of breath, chest tightness. And then you'll hear that there's also medication types of combo medications. So these are devices that contain both a bronchodilator and an inhaled corticosteroid. And these can come in either 2 medications in one device or 3 medication in one device. So we understand this can be quite overwhelming. So hopefully we're going to help answer some of these questions in the coming slides. Okay, so I mentioned before, we talked about bronchodilator and inhaled corticosteroid. So let's take a little bit more of a glance into them and compare them a bit. So if you look at bronchodilators, these are, like I mentioned, they relax those smooth muscles that constrict those airways. They can come in two forms. They either can be short acting or they can be long acting. The onset of them typically are anywhere from 3 minutes, so that's your short acting side, to around the 20-minute mark. So depending on what medication, they all kind of start at different time frames. They can be scheduled or be used as needed. So our scheduled ones typically are our long-acting ones, the ones that we want to take the same time every day. They provide the bronchodilator effect for 12 to 24 hours. And then you could have some that are just used as needed. So those are typically your Ventolin or your Symbicort. When you're feeling short of breath, take a puff as needed. These will improve when you take these ones, you typically feel improvement in our symptoms right away. So like we said, that bronchodilators help relax those smooth muscles. We're going to feel that shortness of breath relief from these medications. On the other hand, inhaled corticosteroids, like I mentioned prior, this helps reduce that swelling inside the airway. So when we have swelling inside the airway, it's going to narrow and it's going to restrict air from moving in and out, also causing that shortness of breath feeling. But we're going to touch a little bit in a minute about how taking these medications may not reduce that sensation of shortness of breath right away. These medications are to be taken as maintenance, so not as needed. So if you take something that has an inhaled corticosteroid in it, these need to be taken daily. They will not work as an as needed here and there. They need to be taken daily. So they have a slow onset time to work. So you start taking them, they usually take anywhere between 1 to 3 weeks regular use, so morning and night, to really start feeling the effects improvement. So inflammation is not going to go away right away. After about the 3-week mark, that's when patients start to feel that, I'm starting to feel an improvement in my shortness of breath. So that's kind of the difference between bronchodilators and inhaled corticosteroids. Give those inhaled corticosteroids some time to work before you feel that medication isn't doing or is or isn't working for you. So lastly, I also talked about that the medications can come in either single therapy or combination therapy. So there's pros and cons to both. So if you get a medication, you have something like Spiriva. It comes in a device. It has one drug in that device. However, we're going to talk about controlling of your COPD. Sometimes we need more than just one bronchodilator to help manage your symptoms. You may have a long-acting bronchodilator and then require also an inhaled steroid. So now you have 2 different devices, 2 different drugs, and it can be confusing on remembering how to use one device, how to use the other device. This one needs to be used at this time. So sometimes having a lot of those devices can result in error and forgetting to use your medication. So a combination therapy is where that one device contains multiple drugs in there. So you have usually a long-acting bronchodilator and an inhaled corticosteroid. And then in some of them, we have 2 bronchodilators with an inhaled corticosteroid. So the benefit to this is you've got to carry less devices. You have to only know how to use one device. So there tends to be a lot less air and better control of your COPD due to this.
And better adherence too. If you only have to use one device that has all your medications in one, why not make it simple, right? The KIS little saying, right? So there are, as I'm sure most of you know, there are multiple types of devices that you can use or that your medications come in. The high number of different types leads to greater chance of not using it properly, not getting your medication deposited properly. And so we're going to go through those devices today, the most common ones, and talk about the best ways to take them. So hopefully you start to optimize the medication that you're getting and feel like you're actually getting a benefit from it. So I love this slide. This one I always fight Alexa to go through because I know it's a full image. It's quite a bit of information, but as you can see on the left-hand side, it talks about high, medium, low, low, and then your PMDI, your pressurized MDI. That is the flow rate or the inspiratory flow rate that you have to generate in order to suck in your medication into your lungs. And as you can see, the wheel goes from that nice PMDI all the way to that purple. And purple is high, which means you need a high inspiratory rate to actually get the medication in. So each device has different requirements. Your inspiratory flow, dexterity. Can your fingers and your hands actually work your medication? Any accessories that might need to come with it, and then the medications that actually go in there. So it's important, I know all of our healthcare providers are very busy, so it's important for you to be your own advocate. And if you feel like your medication or your device isn't the correct one, learn how to take it properly. If you still cannot do it, then we need to investigate something different for you. Okay. So the first one is your MDI. Show of hands, how many have an MDI with this spacer at home? I do. I sure do. Anybody else? Heck yeah.
Oh, yeah.
And I said spacers, so hopefully you all have spacers with you. So this is kind of the old school grandfather, whatever you want to call it. This is the device that most medications came in originally, and a lot still do. It does use a propellant to, like a gas, you have to shake it up to push the medication into you. Okay, you do not interact with that medication. You breathe it in and you breathe it right back out. So there should be no concern over that. When it's brand new, straight from the pharmacy, you can ask your pharmacist to do this, or you can do it yourself, but you have to do what we call priming it, which means you got to make sure that the device actually works. So when it's brand spanking new, you shake, shake, shake 5 to 10 times, and then you go 1, 2, 3, 4 actuations or puffs in a row. Okay. That's to make sure that it's actually pushing medication out to you. If you don't get anything, turn around, go back to your pharmacist and say, I don't think it's working. Okay. For every 1 dose that you get, so every 1 puff that you do, you need to shake the device 5 to 10 times. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then wait 30 seconds for that nice pressure to build up inside so the device can give you 1 full dose. Do not do multiple doses in a row. It does not mean you're getting, if you do 2 pumps, you're not getting 2 doses in a row. You're getting 1 and maybe a sad little tail end of something, okay? So it's shake, 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 wait 30 seconds, and then give it a pump, okay? It may or may not come with a dose counter on it. If you have an orange one that has the inhaled steroid, most likely it will come with a counter, but you can see the blue ones, your salbutamol, may not come with a counter. So on the canister, the little metal thing you can pull out and it will show you how many, and it's up to you to keep track of how many doses you've taken. So you waste 4 when it's brand new, and then how many times a day and how many doses a day, and that will give you the number of days that you should have before it's empty, okay? Now, it's recommended to always use your MDI with the spacer. And why is that? Well, that propellant shoots that medication straight out of that bad boy, and if you just put it straight in your mouth, it's just going to hit the back of your throat, okay? You're not fast enough to breathe in that medication and pull it down into your lungs fast enough. So we use that spacer. It slows that burst of medication down, so then you can take your nice, slow, long, deep breath in. Just like that. And you only do 1 dose in the spacer at a time. And as soon as you put that dose in the spacer, be ready to breathe in, okay? If you let it sit longer than about 5 seconds, it will settle and stick to the sides of the spacer. And so if it's longer than 5 to 10 seconds, go ahead, shake, 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 and do another dose in there, okay? This is Alexa's new toy.
All right, so I'm just going to jump in while we're talking about MDIs. So there is a new triple therapy MDI that is on the market. And sometimes it's confusing to some people because this new MDI that's on the market, it is a triple therapy. So meaning that it has 2 bronchodilators, so 2 different forms of a medication that's causing bronchodilation in the airways, telling those muscles to relax, and also has that inhaled corticosteroid. So it's reducing that inflammation inside the airways. So 3 drugs within 1 device, which we know is great. It's going to reduce that air. It's going to keep you more compliant with taking your medications. However, this one does not necessarily need to be used with a spacer, which may be confusing. You may see someone, we drill out there, like use all your MDIs with a spacer, MDI spacer, MDI spacer. Well, this one, the particles of how they're designed, they're these teeny tiny particles. So when you breathe them in, they're not going to be sticking to the back of your throat like we see with how fast the spray of other MDIs are. So studies have shown that the deposition down into the lungs without a spacer because of that extra fine particle size, you're going to get that medication down to the lungs, unlike the ones that we see on MDI. So they have this special air sphere into these particles. They're allowing that aerodynamic structure. It's like the ultimate optimal size to be able to get down into the lungs. So you may see this now in the market, or if you do have the Respiratory, you don't need to use it with a spacer. However, we do have therapists that are saying, you know, you should still just, it's not going to hurt if you want to use it with the spacer, especially if you do have your Ventolin as a backup for relief, so that there isn't any confusion. So if you are not using the Respiratory, remember, use it with the spacer.
Wonderful. So this is a very busy slide. Again, please refer back to it at the end of the presentation when this is posted online. There are the steps to go through to actually use your MDI, but just considering time and making sure we can answer all questions, we're not going to go stepwise. But do remember that if it's brand new for your MDI or you have not used it in 2 weeks, please shake, 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 and waste about 4 puffs and write those puffs down. Only put 1 puff of medication into your spacer at a time. So shake, 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 5 to 10 times, wait your 30 seconds. And I shake my MDI while it's in my spacer. You don't have to have them separate. You can shake everything together at once. Once you puffed it in there, exhale to the side, lips nice and snug, sitting nice and tall, and nice, smooth, slow breath in. Fill your lungs up so you feel as though you'll float away, and then hold your breath for a count of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and exhale through your nose. When you do your slow, smooth inhale, I almost do it like I'm inhaling through a straw. If you hear a whistle, you're going too fast. Slow down, okay? And keep track of your doses, write them down if you don't have a counter. And then after you've taken your doses, however many there are, if it is an inhaled steroid, rinse, gargle, spit. And we will talk about why in a little bit, okay? Now, like I mentioned earlier, oops, sorry, that's okay. Like I mentioned earlier, the medication will settle and stick to the sides of the spacer. They come with what we call an anti-static. Oh,
just trying to get rid of that.
It comes with an anti-static kind of film on the inside, but it will get coated over time and with washing it, and I'll talk about how to wash it in a second. You want to make sure that you're getting rid of any medication that might be sticking there. Okay, so with your spacer, if you have it with you, take the parts apart that you can. So there should be a rubber ring at the end where the MDI sticks in. Some may or may not come with the mouthpiece. You can pop that off as well. In lukewarm dish soapy water, go ahead, you can wash off the mouthpiece, but the actual chamber, just swish in the water. Don't scrub it. If you scrub the inside, it will score it and create nice little scratches for the medication to sit in, and that'll just make things worse for you. So just swish it around, and then you can go ahead and let it air dry. You don't need to rinse it. Rinse your mouthpiece so that you don't taste soap, but you don't need to rinse the actual chamber because those bubbles can add to that anti-cling, static cling film for you. And then just let it air dry and then put it back together and use it again.
Awesome. Okay, so we're going to move on from, we talked a little bit about meter dose inhaler. So Lindsay talked about the ones that you would actually have to spray to go to get the medication. Now we're going to talk a little bit about some of the medications and the devices that contain dry powder inhaler. So dry powder, these types of devices, we actually have to get that medication into the lungs. We're not spraying it in. So an important thing when you think of anything that has a dry powder inhaler, think about what could possibly cause that medication to clump. So we want to make sure that we're keeping it in a dry, cool environment. So keep it out of your bathroom, anywhere where there's going to be any form of humidity. Anything where there's any form of humidity can cause that medication to clump. So think powder, we don't want it to come in contact with any moisture. And like I was just mentioning, you're not going to be delivering that dose by a spray. You need to generate a flow to suck that medication in. So that's why when Lindsay was showing that graph about, what medication is best for you based on your ability to take a big breath in, If you're not able to take a nice, big, strong, deep breath in, these medications would not be appropriate for you. You have to suck this medication deep down into your lungs. So this can be difficult for some patients that have very severe COPD or just really, really strong shortness of breath. When you're experiencing an exacerbation, you can't take that strong, deep breath in. After you are finished using these ones, you can wipe down the mouthpiece, but we will not be trying to get any water or anything like that. So I would use a dry cloth to clean that off. Like we mentioned with the other ones, this is just a quick reference. At the end, when we have question time, if there's any device you want us to go over, we can go over them and demo them. But one device we decided to pick out of the dry powder inhaler was the Turbihaler. This seems to be a very common device. If you have Symbicort, this is what the device comes in. So there's no need to shake dry powder inhalers. You either load the dose either by twisting the bottom, or if you use something like an Ellipta, it's turning the lid over. So you got to load the dose first, and then you got to put your lips over top and you take that strong, deep breath in. You want to hold. We try to hold for that 10 seconds to allow the medication to get deep down the lungs, and then blow it through the nose. Again, keeping this away from any moisture, keep it at room temperature. And these devices, nice thing about them is that they do have a dose counter. So when they either get down to their last few doses, you're either going to see a red flag or the number will turn red depending on what device you have. And that's signaling, telling you, I need to go get my prescription refilled. So I'm just going to quickly go through these ones too with the discus. So these are going to be where you see Ceravent and Advair, probably your more common ones, are found in this device. So again, you don't need to shake this prior to using. We don't want to exhale going into it. You're going to want to take that nice big deep breath out to the side after you've loaded it. And then take that big breath in, hold for 10, again, to allow that medication to get deep down into your lungs, and then exhale away. Again, we don't want to blow into the device to get moisture in there. We're going to clean it off with a dry cloth if you've got lipstick or you got dirty around the mouthpiece. And there's going to be a nice dose counter on there to tell you when you're getting low. The nice thing with dry powder inhalers, all these devices, is that you can't double dose on it. So if you load it or you're unsure if it loaded, just go ahead and load it again, and then you're going to be able to get that dose. Another thing is if you say you loaded this one and you tipped it over to the side and you're unsure if the medication is still on there, just keep it horizontal and then go ahead and load it again. And we can go over any of these devices at the end if you have any questions about them. And then this was the Ellipta. Again, it's a dry powder inhaler. The most common ones that you'll see in this one are your Brio and your Neuro. And then I guess your triple therapy, your Trilogy. These will be the device that those medications come in. So again, we don't need to shake it. There is a dose counter to check on the side. So this one has a nice big large dose counter on it. When you start seeing the numbers turn red, that's telling you to go ahead and go back into pharmacy and get your prescription refilled. We don't need to, if you drop or you not sure if you got that full dose, you just turn the lid onto this over to the side on this one, and it's going to load that medication. And then again, just clean with a dry cloth, and we want to make sure that this one is stored at room temperature. All right, so we've talked about MDIs, so meter dose inhalers. We just talked about dry powder inhalers. I wouldn't say that these are newer-ish on the market. They've been out for a while now. So these are called our soft mist inhalers. So we have on here a newer device option. I feel like they've been out there for quite a while, so I think we can take that off. But it delivers the medication in a mist form so that it's a nice, slow, easier breath in. We don't have to worry about timing it, a really quick breath in. Like our dry powder inhalers, you don't need to suck it right in. But unlike our meter dose inhaler, it's not going to spray out super fast. So it's kind of that in between. You just want to take that slow, deep breath in, and it's going to miss that medication in. So these devices, we either can see CombiVent. So you're going to have either those two short-acting bronchodilators. We see Spiriva in this one. That's your long-acting bronchodilator. And then we have Inspiloto, which it's a double. So it has two bronchodilators in it. So as you can see, there's a lot of different medications, same device. So it just depends on what you have. But to use these ones, One big thing I usually recommend if you use this device, I have tell patients that have your pharmacy, when you go pick it up, load the canister. That can probably be the most trickiest thing for these ones, is that the canister requires quite a bit of force to load it. I know a lot of pharmacies just do that for the patients when they come, or the clients when they come to pick it up, because that can be kind of hard, especially if you have dexterity issues. This one does require quite a bit of priming. So priming meaning is getting that medication going. So once that canister's in for the very first time, you need to waste a few doses to get that spray generated. So it's just turning the base, spraying it, turning the base, spraying it by pushing the button until you start seeing that full mist come out, then it's ready to use. So you just keep repeating those turn and spray until you get that mist. If you have any questions with this, this is something that your pharmacy should be able to even help set you up and do this for you. Lindsay mentioned with the MDI, if you don't use it for a certain amount of period of time, you need to reprime it. You don't need to do that with this one. Once it's primed, it's ready to go. And then another thing with this one that's really nice is it has that nice dose counter on the side, and this one will lock at the end. You won't be able to do any more twists once the medication's done.
And I just want to add in something that I think we keep hammering home. If you're not going to use your medication, you need to reprime it. A lot of these medications are scheduled medications now for a lot of the patients. So we don't see any of you not taking your medication regularly. So that priming at the beginning, yes, but during the actual, you know, if you haven't used it for 2 weeks, shouldn't really have to occur unless it's your bronchodilator, your salbutamol.
Yep, your rescue drug.
Your rescue drug, yeah.
So with using your Respimat, some of the key points to remember: you don't need to shake this one prior to using. This one does not need to be used with a spacer. There was some confusion with that when it first came out, but it does not need to be used with the spacer. It comes out at just such a slower rate. You just have to take that slow, deep breath in. This one does require to be primed and for that cartridge to be installed. So if you're having troubles with that, make sure just to reach out to your pharmacy or have them do that for you. And then, yeah, so I mentioned that. So, oh, we're going on to guidelines. Okay, so we have talked about our meter dose inhaler, our dry powder inhalers, and now our soft mist inhalers. So those are the type of devices that are on the market. The other thing that that people get, what we get questions for, is the guidelines. So have you ever wondered, why am I on this medication? Why was I prescribed this certain medication when I know, you know, my friend who has COPD too is on a different form of medication? Why is there all these different medications on the market? And, you know, there's a couple of different guidelines out there, but in Canada, we like to follow the CTS. So that stands for Canadian Thoracic Society guidelines. And we also look at our GOLD, so our Global Initiative for COPD, for up-to-date management for COPD. So these give recommendations, and they're based off research that they continue to do with the new medications on the market. And they give us updates for us clinicians and physicians for how to manage people with COPD. And these give us strategies on where to start people based off of, you know, their symptoms, their severity. And so there's so many different factors that go into play with that. So when we look at these guidelines, they look at effective treatments based off your spirometry test. So it's gold standard to make sure that you have had a breathing test. So if you have a puffer in front of you and you've been told you have COPD and you have not had a spirometry test, I highly recommend going and talking to your primary care provider and asking for a spirometry test, because that is absolutely key to make sure that it's gold standard to make sure that you have COPD and what is the severity rating. So that will be based off a certain number that's on your test. On this picture you hear it says FEV1, and it's a certain number that we get from our breathing test to say, are you mild, moderate, or severe? But that's not the only thing that's going to tell us what medication we're going to start you on, or where the therapy starts. We also look at your symptoms. So you could be someone that has moderate COPD based off of your spirometry test, but you could say, I don't have any shortness of breath. I go hiking, I do all this. We might, you know, that'll tell us kind of where we would probably start you at the low end of moderate. You probably don't have any exacerbation risks. On the other hand, you could have severe COPD with lots of symptoms, shortness of breath, coughing, lots of phlegm, unable to do a flight of stairs, that will trigger the therapist or the physician to say, like, this is where we should be starting therapy. So it's encompassing looking at spirometry, your symptoms, and then your risk of having an exacerbation. So when we look at this table, that's kind of where we start our therapy. The other thing to note, there's been some guideline changes. So some of you may have been on medications for the same medications for a while. If we see someone that comes in that has an exacerbation or their symptoms start to worsen, we used to step up therapy. We're like, okay, we'll add an inhaled corticosteroid, and then once you get better, we'll take you off that medication and bring you back. We don't do that anymore. So this table shows that we just go one direction. We say that it kind of goes to your new normal because we want to prevent you from having that future exacerbation. So you may have been put on a dual bronchodilator. So you may be on Inspirato or, something where you have, Advair. And then now you've had an exacerbation and now you've been added this inhaled corticosteroid. As per guidelines, we're not going to go backwards and take that inhaled steroid away. We're just now going to manage you with that because we want to prevent you from having an exacerbation again going forward. So that's one thing with guidelines that have changed, is that we're not going to step back. Also, in the GOLD guidelines, they've really looked at the effectiveness and the efficacy of reducing mortality for patients with severe COPD and how well triple therapy works. So we'll probably start seeing more and more of our patients on triple therapy, especially in the severe with higher risks of exacerbation rates. So don't be surprised if your physician changes up your medications. It just might be a better fit for where you're sitting.
Okay, so like I mentioned, this may answer a lot of your questions. We're going to go through some very common misconceptions and errors, questions that we get regularly asked, and hopefully it might answer some of your questions that are brewing in the back of your little noggins. So we'll just go to the next slide. Do you just want me to?
Yeah.
Oh, you moved everything. Okay. Oh, there it is. Okay. So the first misconception that we hear quite a bit is, I use my puffers as I'm prescribed, and I don't have any symptoms, so you know what? I'm going to stop taking them. Now, if you are taking your medications as prescribed and you have a good technique, they should be doing what they're meant to do, which is reducing your respiratory symptoms and helping the disease from progressing, right? The disease is still present, but you're managing the symptoms and you're keeping it at bay. Think of this. If you have a heart condition, I have a heart condition, if I feel better and I stop taking my meds, or if I feel better, would I stop taking my medications? No, because I know that my heart condition is still there. It's the same with respiratory conditions. If you are feeling better and symptoms are decreasing, or you're symptom-free and day-to-day life is great, that means your medications are doing what they should. Don't stop. Keep doing what you're doing, okay? The next one is, how do you know that your puffers are working? Because sometimes we take a medication and we don't know what it's doing, and we don't know how to compare from before and after to actually know. But that's what a lot of us actually want, is to know, are they working? So with bronchodilators, do you want to take bronchodilators?
Yeah. So like I mentioned earlier on the slides, we have short acting and we have long acting. So short acting just means that they're going to start quick, but they're not going to last us for a long time. So we see them last, anywhere from like 4 to 6 hours. And then you have your long-acting bronchodilators. Some of them take a little bit longer to start, but they're going to last that 12 to 24 hours. So those typically are going to be more of our maintenance medication, and our short-acting ones typically are going to be more for that quick relief because you're feeling short of breath because you're exercising or you're having a flare-up. Yeah, so our long-acting, I mentioned all that, so slower to work, lasts longer.
Good, yeah. So, I mean, you have to know what kind of medication you're taking. So if you need a fast-acting one, you should see that improvement in your breathing, your wheezing, or just able to take a better breath in a shorter amount of time. If you have that longer-acting bronchodilator, yes, it will last longer, but it takes longer to actually start to work. With inhaled corticosteroids, just like with any medication and any steroid, they are meant to reduce inflammation, but it doesn't happen overnight. You need to take the medication for at least 2 weeks, if not longer. Sometimes it can take longer to actually feel or see the benefits of it, okay? These will not make you feel like your short-acting bronchodilator does. As soon as you take that puff, you will not notice a difference. You got to commit to these. And the most important thing about inhaled steroids, by keeping that inflammation down, it is keeping at bay lung scarring. We can treat inflammation. We cannot reverse lung scarring. Okay. And the last one?
So,
I can do this. Yeah.
Okay.
And please give your medications at least a month. So I know I said 2 weeks for your inhaled steroids, but when you get switched over to a new medication, please give it a month of taking it as prescribed and good technique. If you feel like your medication is not working, the first thing I would recommend is go to your healthcare provider. Make sure you're taking it properly. If you're not taking it properly, it won't work. Once you know you're taking it properly, give it a month before you schedule an appointment with your physician or your healthcare provider or your respiratory therapist. Okay. Good. And
misconception number 2, I don't need to take my inhaled corticosteroid every day as prescribed. I only have to take it when I'm having a flare-up. If you are prescribed to take any medication that contains an inhaled corticosteroid, this is to be used as a maintenance medication, and it needs to be used or taken daily in order for it to work. So why is this? So for inhaled corticosteroids, so this is your Flovent, and you're found in your Advair, we're found in your Trilogy, your Respiratory, so it's found in those types of medications. They need to be taken daily because that's how it's going to control that inflammation. It's not going to work with one puff. It takes a few weeks to get that swelling in your airways down, and we want to keep that swelling away because, like Lindsay mentioned, increased inflammation and swelling within our airways is going to lead to scar tissue buildup, and that scar tissue buildup, we can't reverse that once that occurs. So it usually takes somewhere anywhere between 1 to 3 weeks before people start to feel the effects of it. And really give yourself at least a month, if not 3, after initiation before thinking like this one isn't for me. So think of this. Have you ever sprained your ankle? How long did it take for the swelling to come down? Probably a couple weeks for that, icing it, really comes down, depends how bad you do it. What did you do to bring the swelling down? You used medication, you used ice. It's the same thing for our lungs. We can't ice them, so we need to use our inhaled corticosteroids to reduce that swelling.
Misconception number 3, yet again, has to do with inhaled steroids. This is a really common one we hear, and it's a concern for patients that are 5 years old all the way to however old we are. Okay, I'm not going to say, I'm too old. But one of the most common concerns that we hear is that taking an inhaled steroid is going to cause side effects that are bad for our health. And we hear it all the time. Now, inhaled corticosteroids, keyword inhaled, they are designed to treat lung issues, okay? And they're designed to only deposit within lung tissue if it is taken properly. So this will help. We're hammering this home. Your inhaled steroid is such a friend, will reduce your inflammation and slow your disease progression. When you take a medication orally, if you take a pill, pop it in your mouth, you take a swig of water, down into your tummy it goes, your tummy digests it, it goes into your GI tract, and it gets absorbed into your bloodstream. That's why it's called a systemic corticosteroid, okay? Because it's going to affect your entire system, your entire body, because the bloodstream goes everywhere. It's not targeted to one area or one organ. With our inhaled steroids, they are targeted to your lungs only. And when you take them properly, that's where they'll act and exert their effects. So that misconception of your inhaled steroid affecting your body, if you're taking them properly, you should not experience this. Okay.
So why do I have to rinse my mouth after I use an inhaled corticosteroid?
Because your breath is bad. No, not good.
No. It's super, super important. If any of your medication have an inhaled corticosteroid, you want to make sure that you rinse, gargle, spit, because we want to reduce that potential of getting that oral thrush or oral yeast infection. It's very painful. It's uncomfortable. So just make sure that you rinse, gargle, spit. We don't want to swallow that water. So if you take your puffer and you're like, oh, yes, I do that, and I just take a sip of water after, like Lindsay mentioned, we don't want that to get deep down into our body, because then it's going to go systemic, and then we can see the side effects from it that way. Rinse, gargle, spit it out after.
And either brush your teeth or rinse with water, not juices, because a yeast infection, anybody that's ever made bread before or anything with yeast, it loves sugar.
Yes.
Okay. Good.
MDI without a spacer. I love this one. So misconception number 4. I do not need to use the spacer with my meter dose inhaler. I feel like we've driven home this at the beginning, but I get this question a lot. So I think it's super important to talk about. Unfortunately, this can lead to medication sticking to your mouth and not making it to your lungs where we need it to work. And this can lead to, again, systemic absorption. So the medication getting into your bloodstream where we're going to feel those side effects. Usually with these ones being, if you're Ventolin, they're going to make you feel super shaky. And then if it's something with an inhaled corticosteroid, you're going to have that potential of getting an oral yeast or oral thrush or any of those types of side effects from those medications. So why is this? All of them, meter dose inhaler, except for Respiratory, like I mentioned, come out at a super fast speed, and they're going to stick to the back of your throat instead of making it deep down into your lungs where that we want that symptom relief. So I like to think of this analogy. If you're driving a car and you're going down a straight stretch and you're starting to come up to a corner, or you're starting to come to a spot where you're going to have to make a turn, what do? You slow down. You don't keep at the same speed because you need to make that 90-degree angle to get around the corner. Your medications need to do the same thing. And the spacer helps increase the distance from the spray to the back of your throat so that those molecules have time to slow down to get around the corner and down into your lungs where we want them. So less medication back of your throat where your blood vessels are, less is getting into your bloodstream, causing those symptoms or those side effects, and more down into lungs, reducing those symptoms.
We're going to talk about another MDI misconception. Now, because they don't commonly come with counters, especially the rescue drugs, we have seen in the past, I haven't seen it recently, but it's something worth talking about, is, am I doing shaking in between puffs? No. Oh, I thought I was doing canister. Sorry, doing wrong one.
That's fine.
Not shaking and waiting in between puffs, okay? As I mentioned before, please do not actuate the canister. Don't push down on it multiple times in a row. You will not get multiple doses, period, okay? The way that it is required, that propellant that is in that canister requires to be shaken up. And just think about shaking a can of soda. You shake, shake, shake it up, and pressure builds inside. You got to shake 5 to 10 times, let it sit for 30 seconds, and then actuate it. And that pressure inside that canister will push out that one dose, that one full effective dose to you, okay? So you must shake in between, okay, and wait your 30 seconds. If you administer, like I said, multiple puffs in a row, you will not get multiple doses. You may think your medication is not working effectively because the technique is not being done properly.
And I think something to add on to that, sometimes people are like, well, I see the puff come out. If you do not wait that 30 seconds in between, yes, you can still puff it, but you're not seeing medication. It's actually the propellant you're seeing. So that gives people a kind of false sense of, oh no, I got the medication, I saw the spray. Yes, you can still spray, but that spray will not have a medication in it, or very little.
Which leads to this one.
Next one. So this is the last misconception we're going to talk about, or error. I can put my MDI canister in water to see if it's empty. This is an old trick that was used. It was an old wives' tale to see if it was empty or not. Unfortunately, it does not work with meter dose inhalers that are on the market now. Older generation of MDIs used to use a different type of propellant called CFS or CFCs. And when the canister was full, it would sink. And when it was empty, it would float. However, this does not work with the newer type of propellant that is on the market. So how do you know if you do not have a dose counter? So if you don't have Advair or the ones that have dose counters on the back, so mostly your most Atrovents and your Ventolins that are on the market, how do you know when they're empty? Unfortunately, you need to count. So when you receive that meter, when you receive your flow, for example, you receive your Ventolin for the first time from your pharmacy, it'll tell you on the top how many doses, so 200 doses are in there, and then you are responsible for counting down. So you have to remember some additional things, like if you prime it, so we waste 4 to prime it, you have to reduce, okay, 200, now -4. So some tips that I've given some of my clients in the past is keep the box that it comes in, and then on the lid, you can start ticking off how many times you've sprayed. And then at the end, it will still continue to spray even if those 200 doses are done. So there's been a lot of times that we've had patients come in hospital and in physician clinics. We do have a certain scale that can be used to weigh meter dose inhalers to see how many doses are left. I've had numerous times clients come in and I'd say, oh, this has been empty. And they're like, well, I've been using it for a week. So they think that they're still getting it, but you're just inhaling that propellant. The other trick that some people do use is if you're using it as a scheduled medication, you can take the amount of doses that say on top of the canister, and if it's scheduled, you can say, okay, if I'm taking this so many puffs a day, it should run out by this time, circle on the calendar, that's when this is going to be out. So those are some little tips and tricks.
Okay.
That was a lot of information.
It's a lot of information. The PowerPoint and presentation will be available in a few days. Do you want to close this out and get it back on us? So I see that there are a few. There we go. And we got to bring this back. So stop sharing your screen, stop share, see where the red stop share is. Yeah, there you go. There we go. So I see that there's a few questions in the chat box, so we'll hit those up first. I hope that Barbara.
Okay. Barbara's question. Can you exhale through pursed lip after inhaling your medication with a spacer rather than exhaling through your nose?
If you are short of breath, yes.
Absolutely.
Do your breathing technique, because as the medication kicks in and your breathing technique will slow your breathing down, enabling you to open up your lungs bigger and get more medication in. So yes, if you are at rest and you are not short of breath, try and use your nose if you can. The reason is we all have these lovely hairs in our nose, and when we exhale out, the thinking is potentially you could trap some of those medication particles, and then if you breathe in through your nose the next breath, perhaps you carry some in. But if you cannot, do not feel like you have to. Go ahead and use your breathing technique. I'd rather you use a breathing technique that helps your breathing.
Yeah, that's going to help stint open your airways, like Lindsay and I explained back in January.
Yeah, forget that.
Yeah, it's going to help stint open those airways. So if you're feeling short of breath, absolutely do your pursed lip breathing technique. Yeah. This next one is a great question.
It's a great question, Chris.
I've never been asked this. So Chris asks, when priming an MDI, do you need to shake between each primed puff? Great question. Not from my knowledge.
No, you don't have to. You can just keep pumping. The reason why you prime it is to ensure that something's actually going to come out. Okay. So they want to make sure that the propellant is actually coming out. So as we mentioned, when you shake, shake, shake and wait in between, that's to ensure a dose of medication comes with each puff. But when it's brand new, you just want to make sure the propellant is actually coming out. So you could shake, shake, shake 5 to 10 times and then go 1, 2, 3, 4. Yeah. And the first one, you might not get anything. The second one might be a little bit more. And by the fourth one, you should hear that and see stuff coming out. So very, very good question. Yeah. You do not need to wait in between those actuations. Great question, Chris. Yeah, thumbs up to you.
Okay, Tennille, can adjuvant cause damage if you don't have COPD or asthma? Because my husband was prescribed adjuvant and had never had a breathing test or been diagnosed with either COPD or asthma.
Tennille, can you unmute yourself for a second? Are you available to do that?
Yep.
Wonderful. Why was your husband given the medication?
Because he was having like he'd have to take a deep breath or open himself up to get a deep breath and stuff like that. So she just prescribed it to him, and he's like, he took a couple puffs and he said he started getting like start going like that for a long time, and he said his chest felt heavy, and so I thought that was weird because he's never had any or been diagnosed. So
was he sick? Did he have a chest cold?
Nope.
Okay.
So there's a lot that could be, it's hard for us because we don't know that, like, we don't know your husband's full medical history. My best advice would be that if he's taking any puffer, like it's to be on a puffer, you should definitely have a breathing test. So my biggest advice is to have at least a spirometry test. If we, all medications, they're going to have side effects. If you have COPD or asthma, they're there to prevent exacerbation. They're there to prevent symptoms. So I would highly recommend, if he's going to be taking it, that he should have had breathing tests to make sure that it's warranted and that it's appropriate for him.
Okay. The thinking might have been Atrovent is a bronchodilator. It's not your rescue. It's not salbutamol, because it doesn't start to work as quickly as salbutamol, but it does open the airways up a little bit, and it works on different receptors in the lungs. So with the salbutamol or Ventolin, it works on oh my gosh, beta 2, beta receptors in your airways, and it relaxes muscles and it opens up the airways. And you have those beta receptors, different types, but still beta receptors on your heart. So sometimes when you take Ventolin, and if you don't take it properly without a spacer and it deposits in your mouth, it can be systemic, and it can actually make your heart feel like it's racing a wee bit.
Yeah.
Right? Okay. So sometimes patients that maybe you come in and you say, you know, my chest feels tight, my airways, and they listen, they hear wheezing. It might take a long time to get in to get a breathing test. So your physician doesn't want you to perhaps wait months on it. So maybe she was just trying. And Atrovent is a good one, as long as you're taking it properly and you have a follow-up.
Okay.
To see if it's actually working and you're taking it properly. And if it was given in the MDI, they should, or your husband should have been told to use a spacer or get a spacer.
No, he wasn't told. I have a spacer for mine, and I told him to use. We used a spacer because I said this is what I do with mine, and it's worked. And so,
and he didn't listen.
Yes.
Yes, he should try that, but he should, if his physician doesn't follow up with him, please follow up with your physician. Okay.
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 Thank you so
Lovely.
much.
You're welcome.
Okay, next question. After pressing puffer into spacer, should we wait 30 seconds before breathing in? No, you do not need to wait 30 seconds. It's just, you give it a shake, you're going to put it into your spacer, put your mouth around it, take a slow, deep breath in and go. So you don't need to wait. Like Lindsay mentioned, if you wait too long, then that medication's going to start sticking to the sides.
Yeah, it's like it's in the air, you poof it into it and it hovers there for a second. If you wait too long, it's just going to sink down like a mist and stick to the sides of the spacer. So you want to inhale. Essentially what I do when I take it is I'm shaking. I take a breath in, I exhale, I poof, pop my mouth on and go. So it's a smooth transition. Okay, good question though.
When you are priming Ventolin, do you have to wait 30 seconds between each of the 4 puffs?
No, as we mentioned before. Yeah, you shake, 1, 2, 3.
Again,
4.
it's just getting that propellant kind of mixed up into the medication. When we get the canister, the propellant sitting at the bottom and the medication is sitting suspended at the top. So when we shake it up, and then we want to get it all mixed up so that the propellant's in there, so we don't have to wait in between.
This is $1 million question next.
All right.
Marja,
I rarely use my Ventolin. Why can't manufacturers add a counter? We don't love that.
It would be smart because Ventolin is a very common medication to be used, and it would be very beneficial if they added a counter. If you can figure it out and get it going, you're going to make a lot of money, my friend. Good question. Can you use your rescue inhaling from using Respiratory? That's a you question.
Yeah. The question for Michael, can you use your rescue inhaler? So I'm assuming you mean Ventolin, if you are using Respiratory. So yes, I wish I could go back to the slide. It's okay. There's a slide.
But then you have to share your screen.
Yeah. Okay. How do I share my screen again? That's okay. So based on those guidelines that I had popped up, if you're using a triple therapy, so Respiratory is going to have your inhaled corticosteroid. It's going to have a long-acting beta agonist, so a long-acting bronchodilator that works on beta receptors that are on your lung, and then a long-acting antimuscarinic, so a different type of receptor that tells your lungs to bronchodilate. But these are all long-acting. So Respiratory it's a maintenance medication, so it's used once throughout the day. If you are feeling shortness of breath, or we tell people if you're going to go exercise or do strenuous activity, take your Ventolin prior to that to help give you that like shortness, or to give yourself that relief prior to that. You can absolutely. So within all classifications from mild all the way to severe, short acting beta bronchodilators, so Ventolin, can be used as needed. So if you see anything like PRN means as needed. So If you're feeling that, I feel like maybe I'm having a flare up, absolutely, you can use that as needed. If you feel like you're having a flare up though, please reach out to your family care provider.
Yeah.
But if you regularly use it because you're going to go do strenuous activity or anything like that, then you just use a couple puffs as needed.
Yeah.
Absolutely.
But your rescue inhaler is there exactly for that reason, to rescue you. If you feel a sudden onset of shortness of breath, please don't think you cannot use it. Please use it. Okay, relieve that shortness of breath. It's the worst feeling in the world.
What is the difference between Respiratory and Trilogy? Great question. So these are a lot of the new medications on the market. So we're starting to see more and more triple therapy. So triple therapy, like I mentioned, 3 drugs into 1 device. Again, the benefit of that is that you're not having to use multiple different devices to get the 3 drugs. So before in the past, we would see someone on Spiriva with, your inhaled corticosteroid, or we would see someone on something like a dual therapy, like your Advair with another long-acting bronchodilator. So this is containing both bronchodilators and an inhaled corticosteroid into 1 device. So the difference between both of them, they both do the same thing. They're both going to have that. They're just different drugs. So we say there's a lot of different devices on the market. Each one of those devices have a different drug too. So the type of long-acting bronchodilators are different. The type of inhaled corticosteroids in them are different too.
Yep.
So the difference between Respiratory and Trilogy are that the devices are also different. So Trilogy comes in that a dry powder inhaler. So like Lindsay mentioned, you need to do that strong deep breath in to be able to get any dry powder inhaler. If you feel that you can't take those big breath in to suck to get that powder, then maybe the Respiratory would be better for you, because the Respiratory comes in that meter dose inhaler that sprays out. And then the special thing with Respiratory is that it is a meter dose inhaler that does not require you to use it with a spacer because of the design. The molecule design to it is a lot smaller. It doesn't stick to the airways, so it's able to get deep down into the airway. So there's a couple little difference between that. But if you were to step back from that, they both contain similar properties, that they both contain 2 long-acting bronchodilators and 2 inhaled or 1 inhaled steroid in 1 drug.
Same classifications of drugs, just different devices. And like Alexis said, the 2 different devices, if you store your medications, i.e. your dry powder inhalers, in your bathroom where you have a shower and there's humidity, maybe the Trilogy device or any dry and powder is not the best for you. A lot of us store our medications in the bathroom, but any humidity that gets into that dry powder inhaler could potentially cause that dry powder to clump, and it doesn't declump. Okay, so your Respiratory, yes, it's brand new, but it's an MDI. You don't need a spacer. It can go anywhere. Might be better for you, but that's the main differences.
This next question is so great. How common is it to have a COPD flare-up action plan? Is it a thing that you should talk to your MRP to have on hand? Absolutely. There is a talk, and I believe, I want to say it's in October, that we're talking about COPD action plans. Yes. And Jackie's going to, I believe it's Jackie's going to talk, or maybe it's Tracy. We have a guest speaker that is going to talk all about this. Absolutely. No matter what level you're at, if you're mild, moderate, severe COPD, it is always great to have an action plan, because then you know what to do if you have a flare-up. You may be in the same stage of COPD for a very long time, which is awesome, but you may experience a flare-up. You may not know what to do. And some of the medications we can call what's called like step up. You can take a little bit more if you're having a flare-up. Some you can't. You just want to know what are the signs. So the action plan is going to tell you what signs you're looking for. What is your normal? Because for Lindsay, she may normally have a dry cough for her COPD, but now it's starting to cough up some mucus and it's colored. That's a change, and that lets us know that we're starting a flare-up. I may be someone that has COPD and I normally don't have a cough, and now I'm just starting to have a dry cough. So everyone's symptoms is different, and an action plan is designed specifically for you with your physician or your family care provider. And it just gives direction on what you should do if you're experiencing it. So to prevent you from going into a full flare-up, we might be able to catch it in the early stage to be able to get that treatment going and then not getting into a very severe flare-up.
Now, if you do not have a COPD action plan or asthma, and as Dr. Emily Brigham bring them?
Yeah.
I mentioned there's a severe heat and smoke one. You can go online and you can find an action plan. We will have a talk about this, but if you feel like you want to go ahead and get it ahead of the game, you can go online, search. There's different forms, but they all ask the same questions. Like Alexa said, what is your baseline? That's your green zone. When you feel the best, you can do the most activities. And then it'll say, okay, if you go into a yellow zone, and it'll direct you through it, and then take it to your healthcare provider, because there may be a need for a prescription to be put on file at your pharmacy. So if you do the work beforehand, you can go in and say, look, I did my homework. Can you finish this off for me? So yes, great question. You don't have one yet. We will be talking about it. However, if you want to get ahead of the game, you can look online and find them, just COPD action plan, and you'll get a bunch
And
of
a lot of,
results.
if you are looking to book that with your physician, you have make sure you let them know that's what you're coming in to see, because a lot of those appointments, they make longer than 15 minutes. Sometimes they'll book you for 2 appointments just so that they can go over it, because it won't be able to be done within a 15-minute appointment.
Yeah. We skipped Kathy. Better to use Ventolin or CombiVent?
Message. She was just
Oh,
letting us
I'm
know.
sorry.
That's okay.
There is a question, sorry, asking Ventolin versus CombiVent before exercising. CombiVent has Ventolin in it, and it has Atrovent. So you're getting the benefit of the same medication. CombiVent just has another bronchodilator that kicks in a little bit slower, but it acts on different receptors in your airways. So you're kind of coming, instead of just one action, you've got 2 actions to try and cause bronchodilation. So if you have CombiVent, use it. If you have Ventolin, use it for sure. Thank you for the information.
The last question is just asking where we can get this. All the recordings after we're done is going to be found on the on YouTube, but you could also find it on the BC Lung website too. So YouTube, you can I just usually type in ask the experts, and all the recordings pop up.
Yep.
Or you can just go onto the BC Lung website where you guys would have registered, and there's recordings in the video there.
Yes.
You can, but you don't need, no. CombiVent has Ventolin in it.
So this is a question that was posted just now, and it says, can you take CombiVent when you're taking Ventolin? If you're taking Ventolin, like I just said, Ventolin is in CombiVent. So then what you're doing is you're taking double dose of that. So you'll probably feel a little shaky and feel your heart pitter patter a little bit faster. So if you feel that you want to take CombiVent, stop taking your Ventolin.
Yeah, you shouldn't really be prescribed both of those.
No.
So I would, if you have both of those prescribed, I would either take that back to your physician. We do see this happen where you're prescribed CombiVent, but then you come into hospital. Our formulary in hospital is Ventolin and Atrovent, and we send the patients home with what we give them, and then they go home and they're using their Ventolin, they have their CombiVent what they're prescribed, but you don't need to be using both of those. Ventolin is inside of it, and then you're just getting twice as much of that. It's just gonna cause a lot of side effects.
Yeah, you're gonna feel quite jittery with it, and so perhaps it's just better to, and this is where we have to be our own advocates, is to make sure you know what you're taking and what it does, and that's why your pharmacist is a perfect person to ask, because they can run through it and go, why are you on the same medication? And then they can help you navigate that as well.
Yeah.
Okay, last chance. Any questions? We've gone through all the ones in the chat box. Anybody want to unmute themselves and ask away? Oh yeah. 2 more minutes to ask questions, and then we have to end it. And if you do unmute, please say your name so we know. Hi, Bill.
Hi there.
I saw your
A number of years ago, I bought an emergency oxygen tank, you know, the one that comes in a red bag.
Yeah.
And over the years, I've used it half an hour here, half an hour there, when I've had a bad
Exacerbation or shortness of breath.
exacerbation. So it's worked fine. And I went to get it refilled, and I can't, because you need a prescription for.
Yes.
But supposedly you need a prescription for oxygen.
You do. Oxygen is a
A
drug.
prescription for oxygen is to have your oxygen level constantly below 88%.
There is
There's
I
a
don't have
couple of
that.
things.
So there is a test that you can do, and if you meet the certain criteria, then the government, in combination with your extended health, will try and cover it. However, I have known cases from private practice where patients do not qualify. However, they do still want oxygen. You know, they just feel better with it. Like you said, you use it every so often. So you can choose to privately pay for it yourself. You still need a prescription from your physician for that though.
You have to think about oxygen is a drug. Too much oxygen can cause side effects within our body, especially with COPD. There are some cases that too much oxygen can affect our breathing in a very simple term.
Yeah, I mean, this is a very rare case. So please, if you're on oxygen and you do have COPD, please do not stop using
No,
it. This
but
is very rare.
just think about it. It's a drug. And so that's why it needs a prescription. We don't want to be just giving oxygen to everyone. When we breathe the air right now, we're only breathing 21%. When you get oxygen from those tanks, you're getting it at 100%.
Yeah.
So you have to think about that. It is doing something within our body too. So that's why we don't just go giving it to everyone. It's prescribed, and that's why there's certain tests to see that you meet the criteria for actually needing it.
Yeah. So Bill, go ahead. If you have a healthcare provider, please speak with them and talk about the benefits of it. Perhaps you don't require it. Perhaps it's just having an action plan.
Well, and there's certain forms, like you mentioned the one part of the test, there's a couple different ways that you actually can qualify for it. It's not just 88. So you may have it for ambulation. So it's doing a walk test. You may not need it at rest. You're sitting at rest and your values are sitting above 88. You won't qualify, but see, when you go for a walk or you just do slight activity, your numbers may drop less than 88 for more than a minute, then you would qualify. So that's where it's great to just connect with your family care provider to see, like, hey, maybe when I'm walking, can we get that tested to see if I qualify?
Yeah, good question. Any other questions? Last one we'll take. No questions? We're that good?
Well, they've asked us lots.
I can see somebody giggling at me right now, Ms. Morgan.
Okay, so thank you so much for coming.
We
If
appreciate
any more questions come up, don't hesitate. There's a Facebook group page called Better Breathers. You can always jump on there. It's only open to people with lung condition or people who are caring for people with lung conditions. There's a bunch of us on there that answer questions. You can pop them up there. If not, we are taking a summer break, and we will be back in September with a really great talk. It's planned for September 25th, and we are going to be talking about the RSV vaccine for COPD. So we have a physician coming in to talk about that. The RSV vaccine is a newer vaccine that's out on the market, and we're going to talk about the importance of it and how it can help you getting into this cold and flu season.
Yeah, protect yourself.
Yeah.
So enjoy your summer. Please refer back to any of our presentations during
especially
the
last sessions, wildfire smoke. Stay healthy, stay safe,
change your air filters,
protect yourself if there's wildfires.
stay inside if there's smoke.
Use your puffers.
Use your puffers and use your spacer.
Thanks, everyone.
We'll see you in a few months, everybody. Enjoy your summer.
Thank you. Have a fantastic summer.
You too, Terry. Bye.